Before I begin, I really find this odd as for all webinars. I love the personal touch and connect of looking into the eyes of whom you're talking to. Here I feel like a dodo talking to the laptop, but well, that's okay. Getting used to it. So you have read of a lot of messages of C for corona and C with a whole lot of things. And then C also stands for cervical carcinoma, unfortunately. And the grim reality that as much as you're all worried about the COVID situation, Ca Cervix is rising and it is very much there, and we have our reasons to be worried about it. The incidence is very high, especially in our country. So leaving the stats aside, it's the third most or the fourth most commonest cancer in women. So now less than 45 years, it becomes the third most commonest cancer, but it's very, it hurts when you say that, one lady every 8 minutes dies of cervical cancer in India. We all know about breast cancer, but cancer cervix is not quite behind. So what is our objective over here? So, when you talk of a topic, you would talk of the anatomy, the stages, the response assessment, the role of MR, CT, ultrasound, and an ideal reporting checklist. But the most important objective that I would say is you need to eventually not publish a book. You have to write one report, one impression, which is going to tell your surgeon or your radiation oncologist what they need to do next. If that message is failing somewhere, I think we as a radiologist are not a clinical radiologist and we are failing with our purpose. It's just about then getting another bill generated for the patient. So don't do that. Give your heart out to all the imaging that you're doing. So let us begin with how do you plan a sequence for cervix. So I think it is very essential to get this right with your technicians. I always say this and I keep repeating because no matter how many times you say it is not followed, and a well-planned, a well-acquired image is half your problem done. Because if you cannot see the disease, if you cannot see the anatomy, you don't know what you want to say in your report, right? So this is a sagittal section of the uterus. I have two of them. All right, the uterus is seen very well. So what plane is this going to be? This will be an oblique axial plane, and this is an oblique coronal plane. All right. The pubic symphysis is here, the bladder is here, the rectum is here posteriorly. This is the anterior abdominal wall, some fat, some small bowel, and we have the spine, and that is the posterior musculature. I have an oblique axial image. Do you think this is correct? Yes, it is, but it is not for the cervical region. It is for the endometrial cancers. The cervix is going to lie in a plane over here. So I need to take a planning sequence which is going to run across perpendicular to the axis of the cervix, and this will be my oblique axial plane, and the perpendicular plane to this would be my oblique coronal plane. Why is this important? Because when you are going to do an MRI for the cervix, there are certain particular features you want to see, especially for staging, and you want to see your parametrium. For your parametrium, you want your uterus sitting upright, well straight in the cervical region, and you want it sitting with a nice round in the axial axis so that you can have your better anatomical description. To just briefly tell about the anatomy of the cervix. Again, this is a sagittal section first, and this is the axial section. In the sagittal section, we have the pubic symphysis anteriorly, as I said. This is a nice collapsed bladder over here sitting behind it. This is a uterus which is highly anteverted, anteflexed. That's because the bladder is totally collapsed. Behind that, I have the rectum, and then I have the sacrum posteriorly, and that's my posterior part of the gluteal region. When I look at the uterine anatomy, we have an outer layer, okay? We have a grayish, a lighter gray structure, which is the myometrium of the uterus. And then we have a very thin little black line that we see here, and a little grayish structure. This is the collapsed endometrial mucosal lining, which goes down as the endocervical lining over here posteriorly and over here anteriorly. Anteriorly, what comes down is the anterior lip of the cervix, and posteriorly is the posterior lip of the cervix. When I further go next to it, there is a little black area over here, and I see a little bulge here. This is the fornicial area, and it then goes down as the posterior wall of the vagina. And anteriorly, similarly, I do not have a good anatomy here. The fornix is not seen, but I can trace the anterior vaginal wall over here. This is the axial section, where I see this axial section is taken here at the level of the cervix. So when you see the myometrium is much more hydrated than the inner part of the cervical stroma. So the tissue over here becomes much more compact. So the normal cervix appears very, very dark, almost black on the inner side, and it is a little lighter gray on the outer side. So a section over here in an oblique axial cut is going to give me a nice little oval cervix over here. The little gray here is the endocervical mucosa. We have a little endometrial fluid out there, and we have the parametrial fat around it. Anteriorly, I have the bladder. Posteriorly, I have the rectum. I have the pubic bones on the sides and the musculature. This is a corneal section of the cervix. So let's go from posterior to anterior. I have the bones seen here, and then this is a rectum, which is straightened up. The uterus has just started showing up with the endometrial distended fluid and the uterine body. This is a little darkish partial volume averaging of the cervical part and some part of the cervix seen here. As I continue, what I want you to see over here is a nice black little serpiginous line that is seen on one side. This is the uterine artery. As it goes and feeds here, we see the contralateral uterine artery, and these arteries and the feeding of the artery and their branching is best seen in the corneal section. Again, the uterine artery. So when we trace it in corneal sections, it is seen very well. This is just a little zoomed view where I can see the uterine artery over here coming right till here and then feeding the uterus. Now, when we talk of the parametrium, this is an axial section of another patient. What do I see here? Bladder, small bowel, cervix, parametrium, and the bowel rectum. So there is a very nice article by Valentina which has described how do you define the anatomy of the parametrium on the MRI. So they say that you draw an imaginary line across the anterior lip of the cervix and the posterior lip of the cervix. Then you drop down oblique lines. The oblique line is going to cross across a level, an imaginary plane of the uterosacral ligament. Now, uterosacral ligament is not something which is just sitting there as a very taut structure. It needs to be dissected well in the during surgery, and it goes in like a heart-shaped configuration. So from the uterus, it turns, curves behind, and it goes to the sacrum, and it is blended with the adjacent structures. So that is an approximate contour of the plane of the uterosacral ligament. So we draw imaginary lines. So this is just a pictorial depiction. Now what we are left with, the part of the parametrium which is seen lateral to the cervix over here, this is called the lateral parametrium. What is seen anteriorly is the anterior parametrium, and what is seen posteriorly is the posterior parametrium. Now you would want to say that this should have been the anterior and this should have been the posterior parametrium, but during surgical dissection, this is not really an open space. The surgeon needs to really dissect and get into a space, and if there is no infiltration by tumor, there is nothing really seen at this level which we see on an MRI so well. So we have the anterior, lateral, and the posterior parametrium, and we have the anterior vesicocervical septum and the rectocervical septum. So this is a surgical picture intraoperatively taken where we see the uterus nicely. The fallopian tubes are kinked. Poor thing, it looks so taut and pulled rather. And we have the ovaries here. Now, once the uterus is given a tug, what happens is we can delineate the ligaments well. So we have a round ligament going across anteriorly and posteriorly the infundibulopelvic ligament. And this forms a triangle which is called as the adnexal triangle. When the surgeon dissects further, we have the iliac vessels. They bifurcate into the internal iliacs and the external iliacs. So this is across the lateral pelvic wall of the patient. This is the uterus which has been displaced to the contralateral side, and we are trying to see across the structures of the broad ligament area. And the ureter is very faintly seen traveling here. So once the abdomen, the pelvis is opened up, the ureter is reflected medially. The next is the paravesical and the pararectal space. So these are potential spaces which are not exactly seen very well unless the surgeon dissects out. So what they do is all these spaces are filled with loose areolar tissue and nothing is seen when the patient is opened up, but there is blunt dissection that is done to identify the anatomy that we try to see on our image. So anteriorly, this is the uterus. We will have the bladder here. We will have the rectum here. So the space which is next to it is called the surgical paravesical space, and this is the surgical pararectal space. And we have our parametrial region over here. Again, just another one. The uterus over here is totally taken up anteriorly. It is pulled and it is taut, and posteriorly will be the rectal area. So this is the potential rectovaginal space. And we have the laterally, we have the paravesical anteriorly, pararectal posteriorly, and our broad ligament area. Again, anteriorly, the surgeon has to really dissect to get the bladder seen in the front. Here, the uterus is pushed behind, and that is the cervix, which is seen through the soft tissue. And that is again another potential space not seen unless the tumor infiltrates out there. Obturator fossa, we see the nodes so nicely, but when it comes to dissection, so we see the branching of the iliac vessels, and then everything is retracted. The peritoneum, you are extraperitoneal, the peritoneum and all the structures are pushed medially, and laterally the surgeon has to dip down, or rather dig down, and feel and palpate for the nodes and get the nodes out. So wanting to say here that dissection across the planes is definitely tedious. The visibility surely is poor, and the palpable findings also, of course, I'm not talking of skills of a great surgeon, but meaning to say something which is so well seen on our imaging, we must not falter in trying to give what is our best description. A normal node, nodes are debatable across the body when it comes to imaging on MRI. Various literature have, proposed various findings, and some of them have not. I generally look at nodes as babies of the tumor. So if I have to comment on a node, I unfortunately do not really look at the short axis dimension, which is the norm. I would rather look at the morphology of the node and the morphology of the tumor, no matter which part of the body I'm looking at. I may be wrong, but I feel that the morphology probably has the best say. And a lot of literature is based on older imaging when the imaging was not so great. So somewhere the short axis dimension criteria do not really add on much to your specificity. So I would always insist on taking up, the morphological basis. I just want to show a little very nice little line over here. That's an enhancing node. So something which is so reactive also shows a nice enhancement. So enhancement doesn't help you. Neither does a maintained fatty hilum, as we've seen enough in breast cancer cases. Pathology should be the same everywhere. It is proven at one places and not at the other. So I would say best to stick to the morphology. Now, looking at the MRI protocol, what do we do? So yes, we know the patient is kept fasting for about a few hours, antiperistaltic agents. Yes, we can give. Only thing, when we are only wanting to focus on the cervix, if for any reason, we may do away without an agent, because you don't really have a lot of artifacts coming and blocking your cervix. But if anything a little above, it's always safer to give an antiperistaltic agent. Empty the bladder prior to scan. This is a must. It sounds like just one point, but it makes a huge difference to the patient who's sitting in that cold AC room. First of all, we make them wait after changing for almost like half an hour, 45 minutes, and then minimum is what I'm saying. Then they are taken inside, and again that much time, and they are old, the bladder capacities are poor. So I would emphasize that, maybe an hour or 2 hours before the scan, it's good to empty the bladder. Very simple point, but please don't forget, because what happens is, if you want to give contrast to a cervical cancer patient, what you really want to see in a post contrast is the dynamic phase. I will come to that later. In the dynamic phase, if your patient is going to move or shiver because of that full bladder and that AC, it doesn't help you, it doesn't help the patient. Okay, so please remember this. Consent and coils is okay for vaginum jelly. So times are changing, but still, I think on a single day, if we have 4 to 5 cases of review for cervical cancer MRI coming up, it is very unfortunate that we are still seeing cases which do not have per vaginum jelly. And we don't know sometimes what is happening. What jelly does is it distends up, or it opens up the vaginal cavity. So what is seen as shades of black is nicely separated by a big shade of white in the middle, and the whole anatomy is well deviated. I will show you later. But it's very simple. It's just a catheter which needs to be passed per vaginal opening, and about 10 cc is the approximate quantity. We introduce lignocaine, which is sterile. So lignocaine is introduced, and we just tape it up, and it beautifully distends up the vaginal cavity and the fornices. If you don't give a vaginal jelly, your black and white and gray description is distinction or discrimination is not very great, and your interpretation falls down considerably. So a very small step, I think all of us as a radiology community, if you're not practicing, must be done. The nurses should be trained for that. It's not a very difficult task. Sequences, we have all sequences there in place, but what I would want to harp is, again, when we get scans for review, we are still missing out on the small FOV sequences. Please do not miss out on the small field of view images. They add a world of difference to your diagnostics, and with the little images you cannot really make out much. And if you cannot answer that little one thing which the surgeon wants, it's a wastage of 10 to 15,000 rupees that the patient has spent, and the clinician says, what was the use of doing an MRI and spending all that money? So let's not do that. Let's scan the patient well so that we have better answers to give to the clinician, and their trust is enforced upon us. Okay. And we have some large FOV sequences, just like other areas of the abdominal, dynamic contrast image if you're giving contrast. Now, staging. So one of the best things that happened in 2018 and one of the bad things. So I think in 2018, India had the worst incidence of cervical cancer. The better thing that happened in terms of imaging was that 2018, we had the new FIGO classification. Now, until 2018, it was like a blind era, okay, where the FIGO says that you have to do an ultrasound and a per vaginal examination, ultrasound if available, and then do a staging, laparoscopic staging for the patient. And that is going to determine your stage. Now, there have been so many cases where we see that per vaginal examination is free. There is no parametrial infiltration. Ultrasound is not going to pick up all the minute things. It is good for a gross estimation. So I don't think when we see so many scans, the older FIGO version was substantially fair enough to the patient. I don't think so. But FIGO 2018 has changed. It has accepted imaging on a much more wider platform. The new FIGO 2018 classification states that use an MRI or a CT scan or an ultrasound in that order with whatever is available for the patient. The reason why the old FIGO did not harp on imaging was because cervical cancer is more common in the poorer socioeconomic countries, and people don't have money to get treatment. Where will they go and travel miles and kilometers to get an MRI done? So saying get an MRI done for the cervix does not work in our country if the patient is sitting in a remote area. But now what the staging says is, if your institute has an available imaging, please go ahead with a cross-sectional imaging where MRI in the earlier stages helps, and then of course later stage would be a CT scan, and then depend accordingly. So we have separate notations of R and P, where R stands for radiology and P stands for pathology. So FIGO 2018, I would say, is very, very welcome. There are certain changes that have come in. Stage 1A, we don't need to bother. It is microscopic. 1B is 1, 2, and 3. All right. So stage 1, 2, and 3 is where the tumor is 5 millimeters or up to 2 centimeters. 2B is 2 to 4 centimeters. And 1B3 is more than or equal to 4 centimeters. Now, earlier it was only less than 4, more than 4, of course, beyond 5 mm. So why is this? Because what they realize that across 4 centimeters, the prognostication varies substantially, which is why there was a need to kind of split these into 2 separate groups. So we have a less than 2, 2 to 4, and a more than 4 centimeters in a 1B category. This is an example of the sagittal image of a patient with stage 1B1 disease. The uterus, the myometrium, the inner myometrial area, and then we come down, which is, we know is a junctional zone. When we come down, this is the cervical lip posteriorly. This is the anterior cervical lip. We have a very intact endometrial mucosa, endocervical mucosa. This is an exophytic tumor, partially endophytic, partially exophytic. The tumor is grayer than the normal blacker cervical stroma. This is the beauty of the pervaginal jelly, is what I'm saying. Now imagine there is no jelly. The jelly has not gone over here. What do we see here? This is the posterior wall of the vagina and this is the fornicial area. This is not opened up. Now you want me to tell you whether the vaginal wall is involved, the upper third or not. If there was disease here, I would not have been able to say. So I am failing with one of the answers that the surgeon wants. All right. Luckily, anteriorly, it is beautifully opened up. This is the anterior fornix, the bladder anteriorly, and the anterior lip of the cervix. It is a small tumor, less than 2 centimeters, and I know this is a very early cervical stage. So she has excellent prognosis and there were no nodes seen anywhere. This would be a 1B2 as per the older classification or the newer. This is surely more than 2 centimeters, but yes, less than 4. It is totally endophytic. So yes, it was not 1B2 any longer. This is now coming as a 1B3. Okay. Now, another importance of us imaging over here, because if the surgeon is to palpate this lady, the fornix anteriorly is kind of effaced, but not by disease, it's more by the mass effect. And posteriorly also the fornix kind of seems to be clear. The surgeon would feel a mass in the cervical region. The biopsy would be positive, but nobody would have an idea of the extent of the tumor superiorly. So the endophytic extent of the tumor or the craniocaudal length of the tumor, this is what can only be picked up on an MR or an ultrasound. Even a CT scan may fail to show this soft tissue discrimination. So this is where MRI has to be done if it is available to the patient. Another case of a 1B3, where there's a large polypoidal growth coming down here, again, bladder anteriorly, the spine posteriorly, rectum here, the uterus here, endometrial canal, some amount of hematometra over here. And this is like a fibroid-like thing coming down, and you wouldn't really be sure whether it is disease or whether it is a polyp. And this is again the beauty of the pervaginal jelly. We see it in, this is a vaginal area. And see how nicely the jelly has traveled around it, and we can see it all around over here. So I am very sure that there is no vaginal wall involvement in this patient, and that is where it helps us. This is a hematometra seen in a higher section of the uterine cavity. Now stage 2 is when it is going beyond the uterus. We have a 2A and a 2B. Now 2A is when only the upper 2/3 of the vagina is involved, and this tumor could be either less than 4 or 4 or more, which is again a 1 or a 2. 2B is with limited parametrial invasion. Limited over here is in italics because this is mild nomenclature. Basically, it is if there is parametrial invasion, it is 2B. But the moment it goes into too much parametrial invasion, it goes into a higher stage. So I would rather call it a limited parametrial invasion. So what is, okay, this is a case where we see the uterus in the little parasagittal section, but the cervical disease is very well seen here. Pubic symphysis, bladder, rectum posteriorly. Okay, so this is the vaginal jelly in the vagina of the patient, and this is a uterine body. So somewhere is the cervix and somewhere is the disease. I cannot see it separately. I go into a mid-sagittal section, and I can very well see corneal images. We see the tumor, endometrial cancer, other, we have grafts, we have wash-ins, washouts, but for cervical cancer, most often they are hypo-enhancing. But what I would say over the large number of cases that we've seen, that it is a differential enhancement that we see. The best thing to depict it in early diseases, look at the myometrial enhancement and look at the cervical lesion enhancement. If it is different, then you are worried about a disease sitting out there. So we can really see it very nicely over here, sagittal section, and this is the axial section. Again, there is no parametrial infiltration anywhere. It is a very nice disease which is only involving the upper third of vagina. So this is a 2A1. There were no nodes anywhere. diffusion, this is nicely restricted, and this is dark. The other thing where diffusion helps is if I would have seen a little angulation or something over here. So when we are in doubt, it's good to look at the diffusion and the dynamic post contrast. So you don't know whether it is fat or what is it. So I think diffusion and its fat contrast is also very helpful in telling you or picking up for subtle parametrial infiltrations. This is just a fancy image for a little break. Okay, so coming to stage 2A2 disease. So now here, this is just that it is a much more larger tumor. It is involving the anterior vagina here, but the posterior, the lower one third of the vagina is not involved. This would be a 2A2 disease. This is the case where there is obvious parametrial infiltration. So this is how parametrial infiltration is seen. You see that little wavy line and there are these whiskers seen out there. They're seen on both sides, but much more on this side. And so this would be a stage 2B. Now, parametrium infiltration is, so this is the most important role of an MRI if you look at. So to remember, I say to be or not to be, that's your diagnostic dilemma. So 2B is parametrial infiltration, all right? Coming to 3. Now 3 is where again the revised FIGO classification has changed. Earlier we had a 3A and a 3B. Now 3A is once the disease goes further down and the lower one third of vagina is involved. 3B is a little more than your limited parametrium, where if you have hydroureter or hydronephrosis, or it is further going laterally to extend to the lateral pelvic wall, that is stage 3B. 3C1 and C2 is based on adenopathy. One is pelvic, which is locoregional, and 3C2 is retroperitoneal. So retroperitoneal adenopathy does not come as metastatic as such. It definitely upstages, and it is important to comment on them separately. Another thing which the surgeons always want is, or even radiation oncologists, if you're writing retroperitoneal, just don't leave it at that. For them, a good landmark is to see whether is to compare at the level of the renal vessels. So you can say retroperitoneal adenopathy below the level of the renal hilar vessels or superior to it, because that changes the surgical incision, the surgical approach, as well as the boost for radiation. This is a 3A, where we have the uterus here, the endometrial fluid. The disease extends from the uterine corpus to the cervix and down into the anterior vagina, almost involving up to the lower third. And the posterior vagina is so very well delineated, it is not involved. The bladder is also totally free. This would be a 3A. Now, 3B. This is another debatable topic which we often discuss in our multidisciplinary meets as to what is the lateral extension and what defines your lateral extent of tumor. So when you look at the radiation oncologist, they would say that they look at the inner vessels, the inner wall of the external iliac vessels. So if the tumor is sitting very close to it or about a millimeter close to this distance, they consider it as extension to the lateral pelvic wall, and that matters to them because that will decide how much radiation they want to give in a graded basis up to the lateral pelvic wall. We understand that it is the bones and the musculature covering the bones, which would be the lateral pelvic wall. The vessels are traversing through this. The problem of calculating distances is I personally also have seen the amount of fat. Now, if you look at this lady, she has a lot of anterior subcutaneous fat also in general. And there is a lot of fat over here. So if this lady was a very thin asthenic lady, the amount of intra-abdominal, intra-pelvic fat over here may have been lesser. In that case, this disease here in the cervical region with biparametrial infiltration, it is stopping here. It would have gone much more over here. Okay. So this is when we see a very abrupt stoppage of the disease across a plane. This, I think, it is very close to your lateral pelvic wall infiltration. The surgeons deny of an existence of a true anatomical or a true surgical plane which stops the disease like this, but we always see it on MRI, and I would say that this is extension almost up to the lateral pelvic wall is how I would report, though it seems to be very far away from the muscle or the vessels that we see. However, I see a little twig of soft tissue here. That could be a vessel, that could be disease. So I would look at my dynamics and my diffusion. Nonetheless, this sign that we see of tumor extending right across and almost stopping across a line should be something which is a more advanced disease. So the same patient looking one section higher superiorly, what am I seeing over here on the left is a nice ureter, and there is another ureter over here on the contralateral side. So bilateral hydroureter, more prominent on this side. And however, luckily, I wouldn't break my head too much in this patient because as I come higher, there is frank parametrial infiltration going in almost abutting my vessel. So there is no doubt this is surely going and hitting the lateral pelvic wall. This is a sagittal reconstructed image where you very nicely see the delineation of the dilated ureter. And this is the parametrial disease, which is seen obstructing the ureter. And we have the bladder anteriorly, and perhaps there are some perivesical deposits also. A mid-sagittal section showing us the disease better. And this is the contralateral hydroureter stopped by this. So sometimes you need these SAG sections, you need to see because the urologist would call sometimes and ask for, what, how much is the length of the ureter involved, and yeah, more questions like those. This is another patient where a CT scan was done. So now something like this, where the surgeon feels that there is disease, there is parametrial infiltration on clinical examination, and they're suspecting a higher end disease. And if the ultrasound has already shown hydronephrosis, we don't need to spend money on an MRI for this patient. It is redundant for this patient. Only indication left would be that the radiation oncologist wants to map the disease for RT planning. All right. However, these patients can also undergo a CT staging almost with near fair accuracy. So this is a cervical disease, very nicely seen here. And there is bilateral hydronephrosis seen on the higher section. This is a patient where I had shown you the parametrial infiltration earlier, and I would say this is a 2B. But what I didn't show you earlier was this node sitting out here. Now, if I measure this node, it is not very different from my artery. This would be some 3 mm or 4 mm in my short axis dimension. So does it mean that I should call it as reactive? No, because this signal intensity of the node on T2 is going to be my tumoral signal intensity. Nodes are not like this. So I don't think we need to be checking more on the sizes. It's time we recognize how the node looks like. Okay. Coming to stage 4. 4A is a 4A and a 4B. 4A is bowel or bladder wall involvement without bullous edema. We'll come to that. And 4B is extension beyond the true pelvis. So this is the case of, is it the bladder? No, the bladder is here. So this is a gross hematometra in the uterus of a patient with a large cervical disease, and that's the vagina, some little fluid or jelly out here. The bladder is collapsed anteriorly. So let us look at the plane. The plane, we would say the cervical tumor is abutting the posterior wall of the bladder, but the bladder has an abnormal signal intensity. Let us trace the bladder wall. It is dark, dark everywhere, but here it is thicker and it is more gray. But I still can see this little black serosal kind of a margin out here. And so is it a tumoral spread or is it not? So this is classically called as bullous edema. And this is because of the congestion or the engorgement in that area. And it is not because of disease infiltration. So this is something you should keep in mind. And what helps the best to diagnose this, I would say, is a small FOBT2, where we see the nice little black line demarcating the two, which you would only see in 1 or 2 sections and not all the sections. So we have to see each and every section very carefully. The second thing that helps is seeing the diffusion. The diffusion restriction in the tumor will be much more than this edematous change in the bladder, but sometimes it may be difficult to distinguish. And the third weapon in your hand is your dynamic post-contrast sequence, where your tumor and the bladder wall may enhance differentially at different points in time of your dynamic phase. This is a case of stage 4A, where we have the posterior vaginal wall. The anterior vaginal wall is just not seen. This is extending out into the perineal soft tissue, frank extension into the bladder, and this would be a 4A. This lady really unfortunately had no idea she was dealing with a Ca cervix, and she presented only with backache. She was sent for an MRI spine, and we see, so she went as a metastasis of unknown origin, primary, and yeah, lung mets and bone mets everywhere. And then there were these retroperitoneal lymph nodes which were, kind of seen well, and then lower down, of course, and she was picked up as a Ca cervix case. Now, talking of adenopathy, as I have mentioned, you need to mention the sites, because even though the surgeon is going to go dissecting out all the areas, it does help them to know preemptively where and how much is the extent of disease. So the perivisceral nodes generally are around your area of concern. We have the internal iliac, external iliac nodes, and the common iliac nodes. Short axis dimension, we always mention I harp more on the morphology. Nodal metastasis, they correlate well with the presence of parametrial invasion by the primary tumor. So if I am seeing a disease and if I'm wondering that is there parametrial infiltration, yes, no, but if I'm seeing one node, which is like really like a metastatic node, I don't think I would want to break my head much, because the prognosis of that patient and the treatment of that patient is pre-decided. Your little bit here and there or raising a concern or a question mark will not change the management. So when nodes are positive, and when you know they are positive, if they are accessible for a histopath confirmation beforehand, so then the patient directly goes for radiation. The patient need not unnecessarily go for a surgery. So even with no parametrial invasion, but pathologically proven suspicious node makes the patient go for a radiation treatment rather than going for a surgery first. Sentinel node dissection is done for cervical patients also, and the commonest site is the external iliac, followed by obturator, and then followed by the parametrial site. So the implication is that at any stage which is lesser than 3B, you must look out for nodes, because this is going to upstage the disease. So a quick cheat can be to first look at your nodes, have a look at your cervix, look at your nodes, look at the entire field of view, what you have, and then start digressing one point after the other. So what are the FIGO recommendations? So as I said, now look at this patient. There is parametrial infiltration high up in the disease. This patient may not have a pervaginal infiltration, which is like very, very obvious on clinical examination. Look at the bulk of the nodes and the hematometra. All this was picked up on the CT scan, but because the patient had not gone to a gynecologist first, the patient had gone to a physician, and the patient was sent for a CT scan. So this same patient has this retroperitoneal adenopathy also. Now, if I was to do only an ultrasound with very too much gaseous abdomen or something, sometimes nodes can be missed. Meaning to say, if you have the technology, you do not stop with an ultrasound. We need to have a complete staging done. This is an example of where, again, a clinician may not exactly find the extent of disease. Bladder anteriorly on the CT scan, also, we can see that there is this cervical region over here, and there's a little strip of a tongue-like tissue which is going here. Now, this, you can also tell me that yes, there is obvious parametrial infiltration going quite close, but not everywhere. It is just a very focal spread. This may be missed on a pervaginal examination, which is why a cross-sectional examination is important. And this kind of a spread is not going to cause hydronephrosis. So if only an ultrasound and a PV is done for this patient, it would be like a early stage 1 disease. Whereas this is almost going to be a stage, would somebody want to tell me, it is going right up to the lateral pelvic wall, even if it is just at one point. All right. So what is the impact of staging? The clinical staging definitely lacked and was found to be erroneous in a whole lot of patients in the earlier FIGO staging. Where do we score over? The endocervical tumor size, as I showed, the extent of parametrial infiltration, pelvic wall invasion, and presence of lymph nodes. The other role of RT planning is going to be like, this is the RT rod. Okay, these are the rods which are passed through the disease of the cervix, and then circumferentially we have radiation being given to the patient. This is the axial section. CT scan planning for looking at the placements of the rods. These are the brachytherapy rods. And this patient was a very, very nice, early disease. You look at the corner section, also small disease, no nodes anywhere. Parametrium was not really involved. It is nicely confined. It's just a contoural change. small disease, but the lady was almost 85 years old. So because of her comorbidities, she went ahead not with a surgery, but with radiation with curative intent. And post RT, there was a very good response of the tumor seen here and complete fibrosis. And the patient has very good prognosis. This was a patient who came with recurrence of disease and of the vaginal wall. So the patient had hysterectomy after Ca cervix, but the vagina is involved, bladder is involved, bowel is involved, with fistulous communication between the two, a very solid state for the patient. And post RT, there was a very nice response. This is intermittent phase, and this is final post RT phase where there's complete fibrosis, and the patient is doing fantastically well. Look at the vault here and look at the vault here. So, well, RT does treat the patients very well. This patient which I showed had a large volume residual disease into. So I want to show you, look at the nodal size in the pelvis and nodal size in the abdomen. And post RT, the nodal size in the pelvis had nearly regressed and still residual disease in the RP area. So this I think does reflect the radiation dose given in the pelvis in the primary area and limitation because of the bowel toxicity. So there is a certain amount of radiation dose that can be given in the abdomen. So we can see a differential response. Spectroscopy of the patient, this is the choline peak, which is elevated nicely. And post-therapy, the choline peak is almost gone. So the spectroscopy also helps us to see in indeterminate cases. This is one patient where she had a lot of disease over here, and then she was given radiation, and the disease is seen over here also in the anterior wall. And post RT, there was this bright area seen. We have the bladder totally collapsed, so vaginal wall, rectum, some fluid, vaginal jelly here. We generally cannot get into too much of jelly in the post RT state because of fibrosis. We have a high signal intensity in the anterior vaginal wall, but in the post contrast scan, we see the nice mucosal kind of an enhancement with no enhancement in the center. So this is classical edema, which is seen in cases with post RT. You can use your diffusion also. We do need to mention the complications. So delayed scan is a good idea to take in cases if you are doing a CT scan for a MRI, CT scan for a Ca cervix post radiation. This is a yet delayed scan where we see the contrast, which is extending across with the fistulous communication and contrast into the vaginal lumen. This is another patient where she had post-RT low backache, nothing really seen much. And then on the STIR, we see that there are these high signal intensity changes, and the review was for whether it was a bone met or not. But we must mention the symmetry on both sides. Look at the symmetry, and let's go back to the T2. And the areas over here, we see a nice higher signal intensity. And what do we see here? So these are likely to be stress-induced fractures, which are because of post-radiation, because they all fall in the field of radiation and they are within your quarter of radiation and they're symmetric on both sides. Okay. This is post-RT recurrence. She was incidentally picked up on CT. So even if a CT scan is done, I think we need to kind of have a little closer look. So what is the role of MR is to detect, to stage, decide the management, and assess response and for planning. The role of CT is for higher and advanced disease and not for early disease. I would just brush through a few cases. I have 10 minutes, I see. So this lady, she again just came with presentation of back pain and radiating down to her right leg. And there is no rocket science in this. She underwent an extended staging examination and there was lung mets here and she had a cervical disease out there. Reason I'm showing is that she had undergone a PET CT actually, and the PET CT showed the uptake very well at all the metastatic sites and the tumoral site. So yes, it was a good investigation for her. This is another case where I would like to pay the emphasis on dynamic post-contrast imaging. Again, sagittal section over here. So bladder, uterus. This is a little bleb of a cervical cyst out there, and a beautiful exophytic cervical mass. I would say its beauty lies just because it is not really infiltrating the areas around. So it's bad to have the disease, but it's good to have an earlier stage disease. But we need to see more. So the fornix is nicely delineated by the vaginal fluid, both anteriorly as well as posteriorly. And we would look at all the sections. The anterior lip is also free. So the disease is only arising from the posterior cervical lip. So what we see in the axial section, so when we are finishing our round check, so this is all nice, but the problem is the soft tissue that we are seeing over here. So is there mild or minimal focal parametrial infiltration from 12 to 2 o'clock? Yes or no is what we need to see. So we look at the diffusion, but such a small marginal change will not be, the resolution will not be picked up by diffusion. So let us look at the MR. So let's look over here. If you did only a routine post-venous phase, we have the cervical disease here, and then so there is something enhancing here, and there is no distinction. We are still not sure whether it is parametrial infiltration or not. Let's go back from our first phase, second, third, fourth, fifth, sixth phases. And what we see in our area of concern is that whatever was enhancing over here is all arterial enhancement. The disease has not yet shown us any enhancement. This is a poorly enhancing tumor. And the fact that your arteries have been enhancing, and this is the plexus where we see arteries and veins intermingling. Now, when I look at this, I know all that I was seeing was just the vascular plexus, and there is no parametrial infiltration in this patient. So this is how we need to go step by step. This is just a routine patient post-hysterectomy. Wanted to show you how it looks on the axial section, and in the diffusion, there is intense restricted diffusion, bright here and dark on the ADC map. This patient, well, somebody had a differential of a psoas abscess because there are these conglomerated non-enhancing structures tracking along the psoas. This is just a reformatted CT view, but we come down tracking, and this is what we see here, and the disease is very well seen tracking along the psoas over up here, and the cervical region shows the disease very well, and there is a suspicious node out here. So the point is that when we are looking at some finding with a certain tuberculosis or some differential in mind, we must look at the entire scan holistically. This patient, she has a bulky cervical disease out here. She was shown in the MDT, and yes, so definitely an abnormal cervix, but the problem was seeing this. The MR of the rectum, or I mean, this is a CT scan, but this somehow did not look good. But my logic said there is so much bulkier disease in the cervix, so this must be a cervix, and somehow it is weirdly going to the rectal area and infiltrating locally and a 4B. But I was wrong, and this was an MRI of the a CA of the rectum, which is going ahead and infiltrating the cervix. So yes, unusual things do happen, and logic does not always work. All right. So the checklist for our imaging would be the site of disease, the size of lesion, and the uterus, morphology of it, approximate percentage of stromal involvement is the anteroposterior or the width dimension of the cervical lip involvement. If it is more than 50%, if you can see that in an earlier disease, the patient will need radiation. Okay, so that is the implication that it has on management. Vaginal involvement, parametrial involvement, and the extent, whether it is going to the lateral pelvic wall, bladder, rectosigmoid colon, lymph nodes, and mention your level of suspicion and any incidentally picked up findings. Yes, I would say thank you. Stay safe in the COVID times, and with the heavy rains outside, I was hoping to see a sun like this soon. Thank you. I think we can take the questions.
Thanks, Dr. Palak. That was a fantastic talk, and even I learned quite a few new things actually, despite being in the gynae DMG. And I think I keep doing that every time I listen to your talk on cervix. So, you know, a few questions on jelly. Clearly, not many people are aware of it. So, people are asking, how do we insert the jelly? Do we have to tape the external orifice? How much jelly should be inserted? And should we do it in every female pelvic MRI?
Yeah, so your first, before I have to ever say into every female pelvic MRI, you have to take the permission of the lady. Okay, please see to it that she's a married woman, or at least if you know that she's sexually active, which she consents, only then do you go ahead with a per vaginal jelly. You do not need in any other cases, it is only for cervix that it helps. Unless you have a endometrioid kind of a carcinoma, somebody's of an endometrium, you want to see the cervix or the vagina, that's the only region. So you have to go by anatomy. You want to see the vaginal fornices well, does it answer your question? You must use a vaginal jelly. Vaginal cancer is very, very rare, but if the clinician says that there's an abnormality in the vagina, even though I'm talking of cervix, you must go ahead with a vaginal jelly also. The quantity really varies. So usually what we do is lignocaine is filled into the syringe, all right, and we maintain aseptic precautions, and the lady is painted, draped. The catheter is passed into the vagina, and then so you cut the catheter. You have two ends, all right, and from the back end you insert the syringe with your jelly. You cannot suck in the jelly. So you have to remove the whole plunger, fill in jelly from behind, and then introduce the plunger for the syringe. So roughly about 10 cc is what you can say. So it depends on the capacity of the vagina. 10 cc something which you can start off. Sometimes it is 5 6 cc. It may be more. And especially when you know the patient is a post RT patient, do not worry, because very often she does have fibrosis. Try 2 3 times. If you cannot introduce more jelly, sometimes just more than 1 or 2 cc also, it's fine. Then you can leave it at that. If there is an overspill, the jelly does come out. You can just simply clean up and tape it and take her for the scan.
Great. Another
It's
person is
just a
asking.
little, yeah.
Good, good.
No, I was just saying it's just a little mental hitch of, just do it in 1 or 2 cases, and that's it. You can then do it for all your cases, and trust me, the image quality is so much better if you don't take small FOBs, if you don't give pervaginal jelly. There's no point of spending that much money for the MRI, because half your patients you would have been able to answer on ultrasound and CT, and the other half you don't know what to say. Right?
All
Yeah.
right. So next question is, so between 1.5T and 3T, is there a preference?
No, not really. 1.5 Tesla also gives fantastic results. If you follow these steps, you get good image quality.
Great. Okay. Someone is asking, how do you quantify the extent of vaginal involvement in the report? So how do you describe
So
it?
in the so we give it as upper 2/3 or lower third, because that's what manages the changes the staging. If you want, you can give 2 centimeters, 3 centimeters, or whatever, because when you know the patient is going to go for an RT planning and your RT person is going to ask, you can quantify. So staging wise, it's only thirds, and otherwise you can quantify. Now, if you want to ask how much for the staging, then you have to kind of divide arbitrarily. We generally know it is just, if it is just at the threshold, measure it. Now your anterior and posterior lens of the vagina will usually be different when you're looking at them on your sagittal plane. That's okay. So if you're seeing the anterior involvement, you talk of the anterior, posterior, talk of the posterior, because the measures in any given patient, look at 1/3 of what you're looking at.
Great. Okay. Um, what if when we see ureteric involvement, we wait. What is this saying? So I think this person is asking, what if we see retroperitoneal adenopathy and ureteric involvement? What stage is it? So that you have already discussed, right?
Yeah, so that is stage 3C2.
Okay, perfect. So let's just leave that. Okay, so someone is asking, how do you differentiate like early cervical cancer from benign or infective etiologies when the history is not very useful?
So see, generally, when you're looking at cervical disease, the benign conditions, I mean, there are not many differentials that you're looking at. If the lady has an abnormal pervaginal bleed, you look at her age profile, you take the history, and usually the diagnosis, you cannot leave that patient without a PAP. So the lady is always going to come to you. Then, if it is a good gynecologist, they know it's a Ca cervix. If there is a doubt, they will have to take a pap smear and then come to you. So usually cervical staging is for cervical MRI is for staging and not for diagnosis. One of the common differentials, not so common though, would be a cervical fibroid, which I would say, or a polyp. So now we saw this one case of cervical polyp. So polyp would also be darker, okay, and fibroids also would be darker. But you must look at the diffusion. So fibroids will also show you a diffusion restriction, and so will a malignancy. The difference is fibroids has a very, this is my terminology, it is a very mottled diffusion. You see these black and white spots all across the fibroid. That is a very classical kind of restriction for a fibroid. Whereas a malignancy is going to give you a uniform restriction. So if you have something which is quite dark on ADC and intermediate on T2, I think it has to be thought for a malignancy and we need to undergo histological staging. If you're wrong, it's fine. So then you don't start giving the staging and everything, but you're not sure if it's a malignancy. Otherwise, then it does not sound very right. So if you know there's a diagnostic dilemma, you can give in all your points and ask for a histopath correlation if you do have a benign differential in your mind.
Okay.
But don't write stage 3C1 for a patient where you're thinking of COX.
All right. A couple of more technique related questions which just came up. What is the B value we use for diffusion?
So around 800.
Okay. And another person asking, can you use a tampon instead of a jelly?
We have not tried, but again, you would have to fill up the tampon with something. I am not sure if, because a little, you would have to soak it with something because air gives you a lot of artifacts on an MR. So unless you have a tampon which is made for imaging, where it is a MR compatible structure and which gives you signal intensity, then you can think of using it. But honestly, I've not tried. But you cannot have any air artifacts because that throws a lot of artifacts. So I would still say a jelly is a good idea. But if there are tampons available, especially for MRI imaging, I would also want to know that.
Okay. If the inguinal lymph nodes are enlarged, what stage would that be?
That goes into metastatic stage then.
Okay. And there are a few questions on parametrial extension. So one person is asking, do we need to just say parametrial extension present absent, or do we report
No.
anterior or posterior and give some measure of how extent of the involvement?
You may not say anterior or posterior. See, anteriorly, posteriorly, you first look at your bladder involved or rectum involved directly, it's a 4A. So it doesn't matter. Now, well, it still does matter when the patient, because it's not just the surgeon's report. This patient will carry the report then eventually to the radiation oncologist. So then you will get a call from there that now how much is the extent. So of course, it's best to give all the description first. But anterior posterior parametrial concept is not yet existent as such, but laterally it does matter how much is the extent of disease up to the lateral pelvic wall or not. So there is a way. So if you do have patients from a fixed referral center or a fixed kind of a setup, you can have an internal conversation and have a medial 1/3, middle 1/3, and a lateral 1/3 of the parametrium. That is another demarcation that can be looked at. It's an arbitrary 1/3, 1/3, 1/3. But if you don't go into that specification, your must require criteria is whether it is present or not, whether there is hydronephrosis or not, whether it is reaching to the lateral pelvic or not. These three answers need to be satisfied. And left and right. Yeah.
Okay. And this is an interesting question. So is there a significance of peritoneal infiltration? Like we talk about rectum and anterior peritoneal reflection involvement.
Yes.
Do we need to mention that?
It is important, and sometimes though literature says that when you see perirectal nodes, actually that's your area, I'm breaching into the rectum, but if you do talk of these mesorectal nodes, you'll find a lot of literature that, oh, it's a CA rectum, but I have seen so many mesorectal nodes in CA cervical region, cervical cancers. So I think somewhere it does relate to not a direct rectal infiltration. It is a well-confined disease with a little parametrial or perhaps a peritoneal infiltration, and then you have nodes even sitting in the mesorectal area. When there is frank disease, like I have shown one case in which I had these sagittal images, then that time you can see the peritoneal reflection area also being puckered or pulled in by the disease. So if you see that, you can mention it because it does matter to the surgeon. But by the time you reach to that level, patients go for RT, they don't go for surgery. So then radiation wise, as far as you map the disease for them, the nitty gritty doesn't matter.
Okay. So a few questions on recurrent cancer. So people are asking, how do you differentiate post-radiation changes from recurrent tumor in the follow-up setting? And is there a role of diffusion and ADC values in that setting?
Yes. So post recurrence, you see changes. T2 signal in T2 weighted images. The signal from a gray tumor becomes black. Okay, there is fibrosis which is induced. Sometimes it is not yet become black. So you always do a complete scan. So first you look at the T2. Next, you'll be looking at the diffusion. Now, when you're looking at the diffusion, the ADC map will tell you that, okay, it was this much before, it is so much now, but not getting into so many details also. If you just see your diffusion weighted single time point, restricted or not restricted. So if you think it is restricted, then yes, it is going in favor of residual. You might tell the radiation oncologist perhaps 1 or 2 cycles more of radiation or a close wait and watch is required for this patient because you're worried. If your T2 is black, if there is no diffusion restriction, and if there is no differential enhancement, then everything goes in a good favor of a response. And then there is bold hypoxic imaging, which is also there. Perfusion is also there, and all these parameters kind of stop dropping down. So post RT assessment on an MRI is a very nice, clean area, and we have good answers for the clinicians.
Okay. So do we need to differentiate between paracolpos and parametrium? Because the vaginal portion of the tumor may be involving the paracolpos rather than the parametrium. Is there a differentiation that you put in your reports?
There is a differentiation, but again, as I said, it doesn't matter because as far as I'm with the same page of conversation with my radiation oncologist, because now this patient goes to the radiation oncologist, not to the surgeon. So as far as you have, described it well, it's enough. You may not mention paracolpus and parametrium separately, but if you have large disease going right up to, the fundus of the uterus and the entire area next to the uterus, you can mention it. So it all depends on how you describe.
Yeah.
It's not necessary.
Pardon me?
No, I said it's not necessary. See, because when you talk of guidelines, we cannot make something so complicated that people will not follow it. So beyond that, it's up to you, how much you want to give in.
Yeah. So a few people are asking about nodes again. I know you covered it, but because 3 or 4 people have asked this question about differentiating reactive versus metastatic nodes, do you want to just talk about it once more in brief?
Yeah, so reactive versus metastatic, I mean, see, when we have COX in our country and there are so many other infections happening everywhere, we cannot really differentiate them too well. But as I said, that I look at a nodal metastasis like a baby of the tumor, okay? So I always look at the T2 weighted imaging of the cancer. That was my part. Yeah. I always look at the T2 weighted imaging of the cervical cancer. I look at the T2 weighted signal intensity of the lymph node. I look at the diffusion. I may not go into B values, but just an eyeball technique, how much restriction in the tumor, how much restriction in the node, and that tells whether it is likely to be suspicious or not. Heterogeneity, obviously, this is a metastatic node, so I'm not getting into that, into post-contrast. But this is a well normal size, small short axis, homogeneously enhancing node. What I use is diffusion and T2 compared to the primary. This is against the literature. The literature says it doesn't help. So, I mean, if you're talking of literature, you need to stick to that, or if you're writing an answer in the exam. But it's not all that wrong to try out for yourself, how sensitive or specific you are.
Okay. One person has commented that they prefer using ultrasound jelly rather than lignocaine for filling up the vagina. I think that's fair, right? I mean, they can use that.
It's fair, but is it sterile? I don't know. So, I mean, ultrasound gel, there are sterile and sterile ones also, but I'm not sure of that. And the other benefit of I see of lignocaine is, it's generally a little more soothing because it's lignocaine. Than something else sitting out there. So of course, if it is a sterile ultrasound jelly, I guess it's fine. Provided read the literature, because there was one point of time but I was looking into Vaseline for some other reason. I wanted an inert substance for CT vaginal distension, and so Vaseline is like inert. Sterile ones are also available, but it is not safe to the vagina. It causes vaginitis. So after a lot of literature search, I gave up my idea. So if you're using something else, I guess maybe just do a literature search of safety in the mucosal lining.
Okay. So a couple of questions. So one is on, do we need to give contrast in all patients or only as a problem solving tool? Another one is on, do we need to do MR spectroscopy? When do we need to do MR spectroscopy?
Okay. So MRI contrast, as a dictum, you should, if you're doing an MRI cervix, you must give MRI contrast. If you're giving MRI contrast, you must do a dynamic. That goes as one standard line. Personally deviating from it, if you ask what is the relevance of contrast in all these patients, If you do really want to personalize your patient's imaging, which I feel may not be wrong, is if you're seeing a very obvious disease or a very obvious parametrial infiltration on the plain scan, and you are not there, your purpose of scanning is not to screen the MR abdomen, and the patient has only come for an MRI pelvis, you may get away with a contrast because there is nothing else that you're going to see except that you're seeing a tumor much more nicer. So it doesn't serve your purpose, or unless you're seeing a very heterogeneously enhancing node. So when your pre-contrast has answered the questions for a particular scan, you may leave the contrast, you may leave it out. As far as you're confident of giving the diagnostic staging for that patient, I think it's okay. It saves money, it saves time, and I mean, patient's comfort also. The second question was spectroscopy. Spectroscopy is very heterogeneous when it comes to body imaging. So unfortunately, we cannot really use it as a standard everywhere. Like even in prostate, spectroscopy had to unfortunately drop out of its specificity because it is so very vague and you cannot get a standardization. So when you are in doubt, like as I said, post RT or something, you have a spectro. It's good to do a spectro. Do it. I cannot say that you must or must not do it. Do a spectro. If it doesn't help, it doesn't help. If it helps, it's good. If you have a pre RT spectro and like a post RT spectro, then it's fantastic. Or if you're really worried about the diagnosis, very high choline, you might be a little more confident of saying that, okay, this is going to be a malignancy. So is it standardized? No. Do you do it? Perhaps you can do it. You must, I mean, you can do it if you, but if it is a known case of Ca cervix, you don't need a spectro. I mean, unless you know the patient will go for RT, then it's a different call.
Okay. Now this question is a dangerous one because it's on anatomy. So if there's infiltration into the vesicocervical septum or the rectocervical septum only, without really
Okay.
extending into the parametrium, would you call
Okay.
it stage 2B or not?
Um, so 2B is whether the parametrial is infiltrated or not. So for this septum, then maybe I mean, if I had to report this, okay, I would not want to write stage 2A or 2B or 3B or anything in this patient. But in my impression, I would really clearly spell out that there is infiltration beyond the vagina. Okay, because usually you're looking at the vaginal involvement by the time you're coming to cervical disease, or you're saying even if the vagina is not involved. So there is pericervical tumoral extension anteriorly abutting the bladder wall. However, there is no obvious infiltration of the bladder wall. So I think I would spell this out very clearly and then leave the decision to them, because then this also would have to go for a RT if it is extending beyond the cervix. So then usually they will go ahead with a with a anesthesia, I mean examination under anesthesia, and take their findings. And then at such times, no matter what you write or report, the surgeon will take his or her call. So again, the management then doesn't matter, but you must write out. And I would say don't get into staging it. I honestly don't know.
That's actually great
Sorry.
advice. So if you're not sure, just describe, and of course you can always pick up the phone and talk to the referring physician. Um, how many weeks after
Yeah,
post?
because you don't want a surgeon to just read, okay, stage 2B and leave it. You know, they've not really, the moment you write a 2-line impression, the surgeon may not read your report. So I mean, like even in breast, you know, sometimes we write like 4 lines on a mammogram and the 4 lines on the impression. So my point is either your impression should be very brief that the surgeon has to read your text, or you are writing all the salient points, then the surgeon will never read your text. Then see to it that all your points are relevant, short and concise in your report. So there are 2 ways of reporting. So you have to decide what you want to follow. So if I just want somebody to read my report, I will give an impression which will take the surgeon back to the text and not give 10 points out of 11 points in a report.
Perfect. So when do you need to image a post-radiation cervix? Is there a protocol, like how many weeks or how many months after radiation do we need to image it, or it's only when there's clinical suspicion of recurrence?
So it is done for both. Suspicion of recurrence definitely is done, and otherwise post RT. So we have trials over here. So the patients who are going on RT automatically fall into trials. So they do have their post MR scans, and they are also on follow-ups. So we have post RT after about 6 weeks, and then we have follow-ups also. So any early recurrence is also picked up. So I don't know the protocol in general, but like as a guideline, but we have patients who are on regular follow-ups after RT also as a MRI for detection of early recurrence. Even when a recurrence is not suspected, they may continue to come for follow-up MR for like I think 2-3 years.
Okay. And indications for PET CT. When would you do a PET CT?
PET CT, you attend any PET CT talk, this is a one-stop shop for everything. So I would say if your patient is not having a obvious parametrial infiltration, then that tells you this patient might go for surgery. Go ahead with an MRI. There is no doubt in it. If there is parametrial infiltration and if there is, probably some adenopathy picked up on some other imaging, then what are you looking at? This patient will go for radiation. So your radiation in your hospital department needs to know what is their protocol. If you are sure that there is no metastasis or something, it is not a very advanced disease, then the treatment of, if the intention of treatment is going to be cure, then just a basic MRI is still okay for that patient. But staging, we again do a CT scan. It is, you do pick up lesions on PET CT. I'm not saying no, but if you start doing PET CTs for every patient with a Ca cervix, when it comes to the advantage of it against the number of PET CTs you had to do, I'm not sure. You'll pick up one brain mets at the primary presentation or something which was missed in your CT, but against what are the odds and how many more patients they'll have to undergo PET CT. So we do a staging CECT, chest abdo-pelvis, and MRI for locoregional examination, as I have discussed earlier. But if somebody is suspecting upfront disease when metastatic, then that's the only time when PET CCT should be taken.
All right. So, another person.
One more thing, I've seen no disease on PET CCT except for the local regional disease, and then patients undergo follow-up PET CCT. That should definitely be stopped. If there is no distant disease, please don't subject the patient to a PET CT again. Subject to what was seen earlier and just evaluate that part. If there is response, then that's fine, unless there's progression. Right?
Perfect. So if it's an exophytic cervical tumor and you assume it's abutting the vaginal wall, but sometimes it's not clear whether it's really infiltrating the wall or just abutting the wall, what do you do in such a situation? This is one of the questions.
If you give pervaginal jelly, that doubt usually doesn't remain.
Okay, so give pervaginal jelly, if that's one thing everyone must remember. Can there be cystic malignant lesions in the cervix?
Just one more thing. If you say that no, the jelly came out, the patient the patient had a stenosed one, or the patient was unmarried and you couldn't give pervaginal jelly, then what is the relevance of your question? If you cannot see, then as I said, don't get into the staging. And if your dynamic has not helped, if your diffusion has not helped, and if your T2 small FOV has not helped, then your odds are you really don't know. So tell honestly in your impression that I'm not sure of the vaginal involvement, but there is no parametrial involvement, and otherwise, except for the vagina, it is a locally confined disease. The rest the surgeon will manage.
Okay, so just last two questions. If it's a large mass and you can clearly see there is parametrial extension on the T2s itself, do you still need to do a dynamic post-contrast?
No, that's what I said. If it's a large disease and there is para extension, like there are some cases which I showed you, it is obvious on T2, you don't need to give dynamic post-contrast.
Okay.
Unless you tell me that the patient is for an MRI cervix of the pelvis and screening MR abdomen. If you're doing a screening MR abdomen and then you want to look at distant disease, then that's when a contrast is okay. But again, a routine contrast may be okay. Dynamic is not going to add much.
Okay. One technical question just came up. What is the small FOV you use?
Small FOV is, I think it's 200 to 180 something. I don't exactly. How much is it, Akshay? Is it 180? I think.
I think it's
180 or 220. But we have them fixed. Yeah,
Okay.
yeah.
So one question I completely sort of missed asking it again, but cystic cervical cancer. So can there be cystic lesions which are malignant in the cervix?
Not that I have come across, much of these. Usually you see cystic changes, but they're like extensions, and the other cystic malignancies are more of those endometrial type, and women with CA breast and on tamoxifen, and they have these cystic endometrial changes going down into the cervix and all. But there's so much disease sitting up there in the endometrium that you're not really thinking of a cervical primary. The disease is stemming from above.
Mhm. So very uncommon then.
Uh,
All right. So of course, there's one thing which is cystic, and that's the younger age group, the adenoma malignum. That I think can be cystic.
Yeah, that can be cystic, but again, I have not really seen cases.
Okay. Would you give TNM staging also, or is FIGO enough?
So I think with the FIGO 2018, FIGO is enough. Earlier, I would personally follow the TNM staging because I found FIGO highly redundant for the reasons I expressed. But now FIGO staging makes a lot of sense. It is much more acceptable and it has embraced imaging very well, I would say. And the reason why so given today's time after 2018, I would say I would choose FIGO because the surgeon still wants a FIGO. They follow the FIGO. So it's better to be on the same page than going with something like a TNM.
Perfect. And I think people are asking if there's any structured template or can you show the checklist again? So perhaps we can email the checklist, the template we have in Tata to the attendees.
Yes, we can. Yeah, we can give a standardized reporting format. It's a little extensive, but once you've reported like 3, 4 of such cases, I think it's fine.
Yeah. Maybe,
I think,
show
yeah,
the
actually, you could
checklist of,
email to all the.
yeah, I'll do that. And maybe if you can show the checklist which you had, that slide, maybe someone, if they
Yeah.
need to take a screenshot, they can take it. And I think those are all the questions. And I'll tell the attendees one more reason why Palak likes the TNM staging a lot, because she has created a TNM app. So if you go to the app store, and you put TNM and Tata Memorial, you will find a TNM app which gives you all the stagings of all the cancers. And that was created by Palak along with Dr. Nilesh Sable, both from our department. Yeah, so that's the imaging checklist. Anyone who wants to take a screenshot can do that. All right. So Palak, thank you so much. I think this was a really extensive and fantastic lecture. Already I'm seeing a few requests for MRI breast and MRI for endometrial malignancy lectures. So probably we'll be having you back soon with those. But thanks a lot. And thanks everyone for